Wonderful, that worked. Hello, everyone. My name is Nicole Bell. I'm the Executive Director of the Cambia Grove. I know many of you, but I also have never met a whole bunch of you here tonight. So I'm going to give some preamble discussions for context for our evening's events. So first off, welcome to our third Anchor Partner Reverse Pitch Day at the Cambia Grove. This is the third event of this type that we've had since we opened. We opened exactly 1 year ago, and so we're going to be celebrating. One of the things tonight will be our first birthday at the Cambia Grove. So Cambia Grove, for those of you who are unfamiliar, is a healthcare-focused industry hub who is engaging Cascadia's healthcare innovators in developing the next generation of solutions. And so what that means to us, and the reason that we exist, is to make sure that in the future our healthcare system is more oriented around the consumer. So you can call them members, customers, patients, but we want to make sure that solutions being driven out of Cascadia focus first on the consumer. That aligns directly with our reason for existence here. And we're also secondarily looking for solutions that drive overall costs of care down in our healthcare system. The best way to stay in touch with the Cambia Grove, and for those of you who are here tonight, it's automatic, is to get our weekly email. So most of you get that already, I know. David at the Cambia Grove is getting quite famous for his weekly reports, and that is David over there by the wall. So you're automatically in. But there are other ways to stay in touch with us. And if you're on Twitter and you're not following Cambia Grove, I'd love for you to pull out your phone. I have props. Pull out your phone and follow us on Twitter at Cambia Grove. Also tonight, one of the things that we are unveiling, hence the bright green t-shirts, is Tiny. So I think a lot of you met Tiny, the large Sasquatch, when you walked in the door. Tiny is our Sasquatch in residence, and he's the newest member of our team. At first, Tiny was an idea to bring in the community in a unique way, but what Tiny has become is a member of our team, and he's going to hold all of us accountable at our events and through social media to be the voice of the consumer or the customer or the member or the patient at Cambia Grove. And so starting tonight, Tiny is with us, and you can follow him on Twitter as well. He's at Talk to SIR, that's Sasquatch in Residence, at the Cambia Grove. So while you've got your phone out to follow us, please follow Tiny as well. I've got a lot of remarks to make, so I have to make sure I hit them all. Thank you, David, for making sure I hit them all. Okay, moving on to one more aspect of the night. So I mentioned that we are celebrating our birthday. We actually opened on March 13th of 2015, and so this is our 1 year anniversary. And so my second prop is a Gravitas Mojito. So in honor of our anniversary, I really want to dedicate our toast tonight to all of you in our healthcare community in Cascadia and in the Puget Sound region. The Cambia Grove is an idea that we executed on, and we are doing what we said we would do, and we are proud of our first year, but it's a movement, and in order to have a movement, we've got to have a community that's very involved, and boy, have you all been very involved with us. And so a toast to all of you and to our birthday. Cheers. We also have cupcakes. So following our reverse pitch, yes, exactly. Following our reverse pitch, you can enjoy the Gravitas Mojitos and also the cupcakes over there celebrating our birthday. Okay, finally, on to reverse pitch day. The reason many of you are here. So tonight, reverse pitch day is special. So I mentioned that this is our third one, but we have not had 3 partners pitching at once. And so our Anchor Partner program is really a signature program that we have here at the Cambia Grove, and it's unique across the country. Tonight, we've got MultiCare, Regence Blue Shield, and UW Medicine pitching to you all for a chance to pilot with each of them. So what's notable about a reverse pitch day is a couple things. So first, if you're an entrepreneur, a startup, or a young company aspiring to or already in the healthcare space, what we do with our reverse pitches is start a process that can lead to a paid pilot with one of these organizations. And so a paid pilot is notable, one, because you get paid, two, because we're dramatically accelerating your path to business with one of these organizations. And third is the result of a pilot, you're going to get that validation, those outcomes data that you're actually solving a problem that large enterprises are willing to pay for. And so that's a unique value proposition why we're drawing a couple hundred people to these events. For large enterprises like Regence Blue Shield, which we're excited to have our first health plan pitch tonight, also for MultiCare and also for UW Medicine, this is really a chance for them to de-risk working with a young company or startup or entrepreneurs, because we put you all through a process that allows them to interact with you in a way that's going to be value added to them. And so that is the reason why we do Reverse Pitch Day in the way that we do it in this fashion at the Cambria Grove, and we're delighted that you get to see it live with us tonight. So our anchor partners are the three tonight have been with us in our first year, and so we're thrilled and honored to have you join us. And we're going to hand it over in a moment so you guys can start off and enthrall us with your presentations that I know are coming your way. And so my job here is to get you guys fired up and to get the mic handed off to Team Elevar. So Elevar Labs is a company based out of San Francisco. They're a group that we have hired at the Cambria Grove to run the process that begins tonight with Reverse Pitch Day. And so I'm thrilled to hand the mic over to Chris Adell, the CEO of Elevar, to take us through our pitches tonight. Thank you so much. Have a great time, and we'll see you at the Cupcake Bar soon.
Mics. How about now? How many people want to land a pilot? All right. How about 3 of them? Well, as Nicole mentioned, the fact that we have just such prestigious companies from the Pacific Northwest here today willing to work with entrepreneurs to solve their most pressing needs is extremely exciting. And Cambria Grove's done an amazing job bringing together the community to allow this sort of partnership to thrive and grow. And Elevar is really excited to be a part of the process to really drive startup solutions to create real game-changing innovations in healthcare. So we have 3 overarching enterprise partners here. MultiCare, UW Medicine, and Regence. I'm sure everyone here has heard of all 3. And these innovations, or these organizations, are seeking innovations from you, the entrepreneur, game-changing innovations that could potentially transform their business as well as yours. Cambria Grove has had an opportunity to bring these parties together and leverage the ecosystem here in Seattle to allow this partnership to thrive. And Elevar will be working with each of the enterprises to uncover their specific needs, identifying the startups that are most aligned to those needs, and then working with the startup and the enterprise hand in hand to bring the partnership together through execution. The way that this program is going to be structured is from this schedule up here. Overall, we're going to have each of the enterprises, Regence, UW Medicine, and MultiCare, have an opportunity to pitch their specific needs. And we're extremely excited because some of the top senior leadership will be here today to actually pitch, proving that they are very committed to seeing innovations in the startup community. And then afterwards, we're going to have a Grove birthday and then the networking event. So let's talk, I wanted to kind of bring everyone to a little story here. What you see is a photo of a health insurance company. It's not based in Seattle, it's based elsewhere. But this is a very typical health insurance company based in the middle of the United States. They serve about 2 million members, bring about $6 billion in revenue a year, and have about 80% market share. So 8 out of every 10 customers in the local region that have health insurance use this specific health insurance company. Now, what's really interesting about this health insurance company is when you walk in the front door, you'll see a wooden box. And in this wooden box, there's a little sign. I think the sign was made probably in the 1950s. It said claim deposit. And this is where members can have an opportunity to drop off their checks. Now, what's interesting is the amount that an average family of four spends in health insurance in a given year is the equivalent of a small automobile. Imagine the fact of having a wooden box where premiums as well as claims and bills can basically be delivered. If you were to have a bank, for instance, such as Wells Fargo, Bank of America, if you were to drop off your mortgage payments in a wooden box, would you see that in financial services? You probably would not. In fact, there would probably be complaints around that. But in healthcare today, in 2016, this is very, very common across the United States, where certain processes haven't yet had an opportunity to be digitized, which creates a huge opportunity for disruption and a huge opportunity to change the system for the better. The reason why this pressure is on is because healthcare consumer needs are changing significantly today. The reason why they're changing are really due to three overarching factors. The first is consumers really want to know that large health organizations have an opportunity to understand the customer longitudinally. As you sort of age, as you go through an experience, does that insurance company, does that provider have an understanding of your longitudinal journey? Secondly, the emergence of smartphones. Now there's a device that allows an individualized experience for each and every patient or member. How can we leverage digital in order to provide the information that they want at any given time in real time? And then third, cross-industry expectations. We're seeing these changes in financial services. We're seeing these changes in other industries. So now there's a pressure to make healthcare sort of follow those changes and progress in that direction. So let's deep dive a little into the individual end-to-end experience. If you could think about your overarching experience through healthcare, would you say that the experience is seamless, unfragmented, and a really sort of easy, navigable process? What's happened is in healthcare today, that end-to-end experience is very fragmented. And it's very fragmented because a lot of these organizations do a very good job at key components, but given the current structure of the healthcare system, it's very difficult to create those pieces that sort of intersect together to create that seamless, overarching experience that's easy and efficient and pleasant for the people involved. And this is not just the customer or the patient as they move through their entire lifespan, but this also impacts the doctors who go through the system. This also impacts the small businesses that insure their employees. This also impacts even the health plans themselves in terms of how they engage with the various stakeholders, such as the provider, or such as the patient. From the smartphone perspective, what we notice is smartphones are not just a technology of the young. If we look at the baby boomer population, in the past 3 years, it's reached a factor where over 50% or nearly 50% of baby boomers have access to a smartphone device. So it's not just technology of the young, but the fact that the largest generation in history to hit retirement age will more likely than less have access to digital technology and know how to use it. And this is occurring at a time when the costs of these seniors are growing dramatically. From age 0 to around age 45 or 50, your healthcare costs remain relatively constant. But by the time that you hit 65 years old, that cost nearly quadruples. And then by the time you hit 85, which is approximately the life expectancy in the United States, expected to go much higher, it doubles again. You nearly spend, in today's dollars, around $17,000 a year in costs contributed to the healthcare system. Finally, cross-industry expectations. I'll give an example of a company that engages in my life. I have USAA for insurance, and I've had them since I was 15 years old. When I turned 16 years old, I received a newsletter geared towards teenage drivers. When I hit 21 years old, all of a sudden they were sending me information for an auto loan. When I hit 25 years old, they started to send me information about mortgages. When I hit 35 years old, they started to send me information about life insurance. What they've done is they've centered themselves around my longitudinal lifespan and tailored services and products and needs geared around me as I evolve, as you could say. The question is, why can't healthcare be the same way? We're seeing it in financial services, products and services geared towards different parts of your life being tailored and leveraging digital in order to create that experience. So the question is, can healthcare operate in this specific way? So overall, as payers and providers start to think about how to create that longitudinal journey, they start to think, how can we sort of become like these financial services companies that are doing it? And the way that they're starting to think about it is we need to leverage digital tools and innovations and think of new game-changing ways to engage customers, engage members in order to drive these innovations through our member or patient population. And that's the precise area where you as the entrepreneur can really come in and create that game-changing innovation. They would ideally, in a perfect world, be able to build it themselves, but they realize that the innovations from some of the smartest minds come from outside the healthcare industry, or within the healthcare industry, but towards the startup audience. So that also brings you guys here today. But it's not as easy as just buying a technology and plugging it. One thing that we have to really mention to you is that in order for an organization to be able to even accept an innovation such as yours, they have to coordinate themselves internally in order to create alignment where the innovation that has an upstream impact impacts downstream and ties in with all these different departments. A lot of these old organizations or legacy organizations that have been around a long time in healthcare and even beyond have very much operated in silos. You have a sales and marketing function that does a very specific thing. In a plan, you have a provider network management function that deals specifically with the providers and has a relatively siloed aspect. Or customer service and claims, they deal with very specific functions. But organizations now have to start thinking about how do we really think longitudinally from the customer journey and get these different departments to interact together. That's the only way that we're going to be able to really support innovation such as yours in order to really drive it through that customer journey. So you realize that the challenge becomes much harder than simply selling a deal. You realize that you actually have to work with these organizations as they start to evolve and change internally as well too. And that's precisely a reason why many of you who've probably done enterprise business development have found it very challenging to work with large enterprise to structure a deal, is because a lot of this effort has to take place internally. So when we start thinking about it from the provider perspective, there's sort of a customer journey or a patient journey moving through 4 stages: scheduling, arrival, visit, and discharge. An example would be for a visit, why does my doctor pay more attention to the computer screen than they do to me? If you're in a 30-minute appointment, you may notice that 20 of those minutes, the physician is staring at their computer screen and there's only 10 minutes that are geared to actually paying attention to you. And by the time you actually are able to have some small talk, your appointment's over. That is not the fault of the provider or the doctor. The reason why is because the doctor is navigating an extremely complicated EHR system and has to mandatory click at least 60 or 70 different menus in the course of that 30-minute appointment. So issues like this become real challenges to the industry where there could be a real need for change, but you realize that having to change an EHR system has a huge impact across various facets of the entire organization. That's one of the reasons why it can be very challenging. On the payer perspective, there's also a value chain element as well too. A member shops and enrolls for a plan, they look for specific health and wellness products, they find and receive the care that they need with a specific provider, and then they work with their plan to basically manage their member and claim information overall. So when you talk about an example like, well, I get an EOB from a payer and it just doesn't make any sense. I don't understand these numbers. I don't understand these terms. Realize that the EOB has gone through this extremely long, complicated, siloed journey in order to get that information to that EOB, and it's not simply as easy as just changing the UI interface of it. There's a lot of issues that have to be involved. So I guess in summary, when you really kind of think about your sort of experience with working with a large enterprise overall, think of it less as a transaction where you sell a deal. Think of it more as passing a bill through Congress, where you are the person that is constructing the bill, the transformative bill, but you need to build consensus and alignment across the key people in that organization in order to create a process or a pipeline for you in order to get that bill passed. And when that bill gets passed, which is extremely challenging, at the end of the tunnel, the beauty of it is you can end up with a transformative set of impacts. When you build a deal with a large enterprise, you are fundamentally having an opportunity to impact millions of patients, millions of members through a single enterprise client. And that's the power of innovation in large enterprise, is the scale in which you can directly impact people. But realize that that doesn't come easy, and that's part of the challenge. But what's nice about this process is we've actually eliminated a lot of the barriers for you to make it a lot easier to get through that process. So to discuss those specific processes, I'll hand it over to Casey.
Okay. So we'll just give an overview of the program if you're a startup or an entrepreneur that wants to engage somehow with these three enterprises. What we see is a lot of value when it comes to startups connecting with and partnering with healthcare companies, but we don't see it as commonplace yet. And so what we've done is we've structured a very specific program, and that program starts today with the reverse pitch. And later on tonight, you'll hear directly from the executives about the specific problem statements that they want your help in solving. After tonight, you will be able to go to our website, elevarco.com, and be able to apply starting tonight all the way up until April 4th at midnight. That online application will then be reviewed based on the type of solution that you're proposing for the particular problem statement and a couple of other criteria that we typically use in our program. Based on that, we will invite a subset of those startups to the next event, which will again be here at the Grove, and it's called Enterprise Challenge. And if you've ever done speed dating, it's very much like speed dating, where you'll have a chance to meet with the executives face-to-face in 10 to 15-minute sessions, describe your solution, get feedback to your solution, and ask questions. Based on that interaction and based on the promise of your solution, the executives are then going to decide who moves on to the next and final round. And that round is called Letter of Intent Day. And this is really where you as a startup have a chance to formally pitch to the executive companies what your solution is. And this can include everything from how you propose to integrate it, how you propose to implement it, what impact it could potentially have on their particular problem statement. And at the end of that day is when the executives will decide which startups receive a letter of intent. And that letter of intent is really a contractual obligation to pursue your solution and a paid pilot. The details of Enterprise Challenge and LOI Day will be given to those startups that advance to that round, including the dates and timing, etc. There's a lot of information on our website, and we are running just a little bit behind. I will allow for 1 or 2 questions if you have them, but there is a lot of information on our website. If there are no questions, we can move on to the pitch. Any questions? All right, we'll move on to the evening.
Great, thanks, Casey. So I'm going to quickly introduce the executives that you'll be hearing from today. They are in the order that you'll be meeting them. So first we have Laurent Rotival, who's the Strategic Technology Solutions CIO from Cambia Health Solutions, sorry. We will then hear from Don Antonucci from Regence Blue Shield as the president. We'll then be hearing from Kat Kozitsa, VP of Digital Solutions, and Dr. Richard Popiel, Executive VP and Corporate CMO. And finally from Derek Weiss, VP of Data Technology and Deputy CIO, who will all be pitching the Regence problem statements. Next, we'll be hearing from Dr. Gianna Davidson from UW Medicine as the Associate Medical Director of Post-Acute Care. And finally, we'll be moving on to the pitches from MultiCare. First, we'll be hearing from Teresa Boyle, SVP of Strategic Planning, Dr. Veronica Hooper, Physician Executive for Primary Care, and Dr. Christopher Kadama, President of MultiCare Connected Care, ACO. So the structure of the reverse pitch will be that an executive will come, give a 5-minute overview of the organization as a whole, and then we'll move on to each of the individual problem statements. There'll be a 5-minute pitch followed by 10 minutes of Q&A for each problem statement. We're going to be really adamant about sticking to time, so hopefully the executives will stay within their allotted time frame, and we will be cutting off questions for each of the problem statements at 10 minutes sharp. So without further ado, I'm going to hand it over to Laurent.
Well, thank you, Aftar. This is really an impressive audience. I have to say I hesitated. I was next to the bar. Usually it's hard to get away. But anyways, it's really an exciting evening, and I think we're all here at the Cambia Grove. I have the pleasure of representing Cambia itself. We've been on a journey for the last 10 years or so, led by our cause. And our cause is all about being a catalyst for the transformation of the industry. I mean, you heard a few minutes ago, and I think most of you probably in some fashion or form are either involved in the healthcare industry or perhaps deeply frustrated by the processes that exist in the healthcare industry and the need to change them, innovate them, and transform them. Our mission is to do so not only at the health plan level, not only at the provider level, but really at the total systemic level, and to tackle the challenges that we all know are deeply seated in this industry, which is all about the tremendous cost, the outcomes, the need for better outcomes, and for better access. And of course, the answers are a little different, region by region, and not to mention individual by individual. What's exciting for us is really a commitment we've decided to have, which is not about solving this with our internal existing infrastructure and technology, but really to reach out to the community. We are a community, we live here in the Pacific Northwest. Our operations are in Washington State, in Oregon, in Utah, and in Idaho. And we also have the privilege of being in a community which not only aspires to probably greater ideals of lifestyle and society, but also has an exceptional demonstration of transformation technology, exceptional demonstration of a startup and innovative culture, and exceptional talent, of course, that comes from those various industries. We have examples right here locally, actually within this building, of companies that have transformed the retail industry, companies that have transformed the financial industry, and we are on the doorstep of doing so on the healthcare side. As we see it, it's all about having a big problem. The big problem that we're going after is not a health plan problem or a provider problem or a lab or pharmacy problem, but is really about solving for the consumer, for the individual, for the N of one. How do we personalize the navigation of healthcare, not just when you have a symptom, but also when you're healthy? And how do we make sure that we can address all of the needs of those individuals from the beginning of life to the end? We believe that we are privileged to be in this community, and I think this evening is a perfect example of that. We have extraordinary talent in this room, high-profile startups, tremendous amount of creativity, energy, and passion for solving certain issues. And of course, we have the technology community, which we believe at this stage, with the maturation of the cloud, of mobile technology that we touched on, we are at the perfect place. And we believe that while some of us, like myself, have been in the industry for more than 10 years, we've been trying to solve these problems for probably 50. But I believe that we are at a sweet spot. The IT industry is mature. Cloud technology now has demonstrated in other industries that it is the way to go. That is where you'll get your nimbleness, your agility, your speed. And the technology is mature enough now to be able to comply, of course, with the regulations and the sensitivity of the data that we're dealing with on the healthcare side. So again, I'm very much looking forward to this evening and to meeting you, and of course to following the process that Alvaro is giving. So with that, I'll introduce Don Antonucci, who is the president of Regence Blue Shield in Washington.
Thanks, Laurent, and good evening. And I've got Kat Kadzitsa up here as well, who's going to help do this 5-minute pitch, and we'll make sure we stay within that time frame here. So basically, our problem statement that we're going after is to really deliver on an engaging consumer experience for all of our members in a way that provides the information, the products, the services to each member at the right time in a way that can help them do things like improve their health outcomes, lower cost, and also make a much more direct connection through Regence because of that simplicity and the ability to navigate the healthcare system. So when you think about how healthcare is delivered today, especially from a health plan standpoint, we deliver a lot of our insurance through employers. And we know that the healthcare landscape is shifting significantly. Well, at the same time, employers are shifting dramatically in how they look at different services and what they need. So to simply provide healthcare coverage and to provide maybe some tools that we would add into that is not enough given the changing workforce and the demand, frankly, for convenience, lower costs, and choice. So when you take a look at what employers are looking to provide to their employees, the experience that they're looking to provide is much more like that we might see from an Amazon or a Starbucks or Nordstrom. So how do we take that and apply it? So what's that mean? Well, areas like mobile on-demand service, finding information at your fingertips wherever you are, whenever you need it, could be an area. Shopping. We know there's variation in cost and quality. How do you get that at people's fingertips so they can use it to find access for whatever's best for themselves and their families? And then when you consider the fact that we're in a region, we're in Seattle, where technology is ubiquitous, where innovation is the norm, how do we create that for patients, for members in healthcare? Because it doesn't exist like it needs to and should today. And so the opportunity with Regence as a start is we have 2 million members in this region. We're well on our way to starting to integrate some of those services and solutions, but I'm hopeful that tonight, beginning with this process and seeing it through, that we can find something that will accelerate us towards that person-focused solution that Laurent talked about and get us there in a faster pace. And with that, I'm going to turn it over to Kat, who's going to talk a little bit more about the details around this pitch.
Yes, indeed. So it's so thrilling to be here tonight, and it's great to be here in the Northwest where there's so many great factors of our technology and this group. I'm relatively new to the area, and one of the things that I love the most about living here is the food. Great food. The IPAs are pretty darn good too, but let's stick with the food on this one. In addition, I work for Regence, where we have an amazing number of ingredients, a lot of solutions and technologies that we've been building over the years. And tonight, I really think about this being our recipe for success, empowering this team, this group, in helping us come up with a better recipe. Now, it also happens to be Pi Day, March 14th. So although Chris said getting work done in a health plan can be akin to getting a bill passed, I'm going to say it's as easy as getting a pie baked. You think about what it takes to bake a pie. You've got some hardware. There's an oven, a mixing bowl, a spatula. Think about that as the technology framework. That might be one of the ways that you help us solve some of these opportunities. Another way is in the recipe itself. There are many ingredients that need to be combined in a variety of different ways. There's a little bit of science in baking, right? And baking soda and powder, which I think do something different, but I've never quite understood that. But think about then the data and the analytics and the algorithms and the way in which you might be able to help us curate the right product to the right individual at the right time. The last is that presentation, when that pie comes out of the oven and it's steaming and the crust is golden, there's a cute little flower that's been cut into the crust. That experience, it makes it appetizing, makes the consumer want to have a bite of the pie. And getting that engagement and that and helping them want to be a part of that solution. So think about the technology, the data, analytics, algorithms, or the experience. Those are all ways you can help us solve this problem.
All right, so that was right on 5 minutes, by the way. Well done. So that opens up 10 minutes of Q&A.
Come back.
Oh, hi, my name's John Pace, and do you have data that shows how the consumer defines value? Maybe a bullseye and a target to help us deliver the best proposals?
So I'll start off, so I speak with a lot of employers and customers in the market, and I think part of what we're trying to do here is define that at a person level, and it is different. When you think about some of the tools that we have in place today that get at shopping, cost service, cost transparency. We find the engagement rates of some people, it's real natural to go use those to their benefit in a big way, but there's a huge portion of folks that don't. So I think what we're trying to do is find out how do we access some of where you're going with the data that then triggers the delivery of certain services and products and information based on their personal needs.
Exactly. So I was actually asking if you have data that we can analyze as we come with our solutions. You see, we have our own personal experience, but if we know the data of your customers, it'll give us quantitative insight as to where to go. You may have qualitative, you may have focus groups. You are the experts on your company, right? And you probably have data on that. It would make us more smart about how we do things if we could have access to that data.
Yes, so we do. We have what you would expect with a health plan. We've got claims data. We've got data in terms of how people access services. We've got data on product preferences. So yes, we do have that type of data that can help shape it. But what I would also say, and this is for the room, is that we don't want to limit our thinking by what a health plan has for data either, or maybe even some of the services. And so the opportunity is to think broader and bring in, which are things that we're doing too, is looking at broader data sets, if you will, to help inform some of these decisions. But
Sailesh Chutani from Obisante. I was wondering if you can elaborate what's the driving force for trying to introduce these concepts, because traditionally health insurance tries everything they can to sort of create distance between the end user and them, mostly by making sure the claim process is as painful as possible. So I'm curious, is this a competitive response to the likes of Oscar, or what's sort of the economic rationale?
I'll start off and then maybe turn it to Kat. So you basically answered the question. We're looking to do things very different. We don't view ourselves as a traditional health plan. In fact, with what we do as a broader company, if all we do is get better at being a health plan, we don't think that's the solution long term. We have to change this industry. So we're trying to do things that are going to be outside of that box to really deliver services for health plan. We also know there's a lot of things that health plans do today that are counter to what we're trying to do, even with this problem statement. So we're trying to go on this journey together and look for solutions that will really transform the way care services are delivered overall. I don't know, Kat, if you want to add on to that.
I might just add that when you think about that entire ecosystem and all the players that come together, we're really trying to shift the gravity of all of that effort to be around the consumer. We're a player, but we have a lot of solutions, and we really want to help activate those solutions to bring the value to that consumer. So it's about making healthcare personal, the N of one, as Laurent said. And that's really our driving force here, is to really bring the activation of a lot of disparate parts together into that seamless experience.
Can I say that as a nurse working out there for the founder of nonprofit, what I see every single day, because of technology, we're speeding things up faster, more efficient. But what people want, especially our age, the baby boomers who are out there, there are 30 million of us, soon to be 72 million of us. These people sitting in your offices and sitting in healthcare don't want faster technology. They want that doctor who actually looks at them. They want that hands-on person. They want that person who looks them in the eyes and gives them the honest. That's where the genuine, real human experience comes from other humans providing the care. So if you can find a way how to make those two work together, that would be great. People don't want faster technology.
Well, and I think you make a great point. It's not just about technology. If all we're doing, and I know Laurent would say this as well, leading our technology efforts, it's not just about technology. However, I would say technology can be a huge driver to creating a different experience for many consumers. But to your point, if all we focus on is that, we're missing the bigger picture of what we're trying to do.
It's really to help get the providers closer to their patients and less time doing that real-time charting, so they don't have to worry about being dinged because the chart wasn't signed right before they left the room.
My question would be sort of a data question as well. Plans have succeeded usually by attracting the well, and so that's your 80-90% consumer that all these things will look very attractive to, and you'll attract more well and potentially financially succeed more. But when it comes to the insurance side, or at least the cost side, that's a great minority of 10 to 20% that you may not have the data to describe, or in terms of what their experience goals are. Any comment upon those two different populations?
Well, I think it goes back to what you're talking about. If you think about it, it's about providing the tools and information that anyone would want, whether they're healthy or sick, in the system. And are there different ways to get that information to them, or are there different ways to stitch together solutions in a way that's going to make sense for people? To give you a very specific example, one of the things I'm proud of in our company is we're leaders in tools that provide cost transparency and quality transparency. We have a company called HealthSpark, which fuels that. The engagement rates are pretty low on that. I think in the industry, it's something like 1 to 5% of people engage with tools like that. So what we also know is that the people that do engage with those tools have a great experience, save a lot of money, and make better decisions for themselves. So part of it is an education piece, part of it is an availability piece that we're looking at here. And so, yeah, it's not one population, but it's any service. And let's face it, we're all going to have different points in time where we're going to want to access something differently based on our situation at that moment or during that month. So we got to look at this much more broadly and not just down a risk segment or down only a healthy population segment. That wouldn't work for this problem statement.
So I'm trying to simplify. This is a big ocean, right? If there's one thing that you want solved, what would it be? One thing.
Part of the reason to have these problem statements the way they are is that we can generate a lot of ideas and outside the box thinking. But I guess, and I'll turn it to you, Kat, if we could solve one thing, I think it would be being able to, back to the mobile example, whether you need to check with a nurse, have a quick consultation with a physician, or find out information about where should I go for this procedure and how much is it going to cost me out of pocket, having that in one spot, I think would be tremendous. It would be a tremendous start. And making sure that, we talked about employees a little bit, that employees knew where that was, went to it. And you think about Uber. How many people have used Uber before in this room? A lot of people, right? So that transformed an industry. And I was walking back today from a meeting in Seattle, and I saw all the yellow cabs lined up. Nothing against yellow cab, but they said, hey, click on my app, and you can, they're trying to get after that Uber experience. But let's face it, Uber has just disrupted an industry with that. So we're looking for things like that people are going to value, and it's going to create a better experience for them, because there's a lot of information out there. But if you'll hear from our chief medical officer in a little bit here, there's also a lot of waste in the system. There's a lot of overutilization of services, but there's also a lot of underutilization of services that create cost in the system. So we want to find ways to help people navigate.
Right, so just to follow up, what I'm hearing you say is all those three things you said at the end are all big problems in itself. So the one is, how does the patient or the member engage and improve their experience? That's number one. Number two is the how do you optimize? And then number three was, what was it over three? Disrupt.
Yeah.
Disrupt. So right. So your main goal is the number one, how the member engages and improves their experience.
You got it. And
Yeah, and I think if it helps also to think about that curation that's involved in that. It's the removal of noise as much as it is to tuning into a signal. And that might also, as you're thinking through like this mass personalization opportunity down to the N of one, down to the individual, that means that you have not only an inventory of a variety of different services and programs to offer, but you've manipulated them in a way with algorithms or otherwise to show just certain signals out of the entire noise of the area. So that's
Helps. Thank you.
Thanks.
all right.
All right.
Next, we have Derek Weiss and Dr. Popiel.
Perfect. Good evening, everyone. Hello, Nicole. What a wonderful introduction earlier. So I'm here to give our next pitch, and it's a combination of me setting things up and then Derek hitting it out of the park, and hopefully we get lots of feedback from you all. So let me start by saying that two news pieces caught my eye today. One was the mandatory requirement in New York of all physicians to use e-prescribing, and two was the return of the newly minted CEO of United Airlines, who a month after the job had a heart attack, and then 2 months after his heart attack had a heart transplant, and now he's on his way back. And it reminded me of a study I did several years back after e-prescribing started, where we started to look at first fill rates, and we looked at 3,000 individuals with newly diagnosed coronary artery disease who were prescribed a statin. Any idea how many actually picked up their script, percentage-wise? Any idea? 30%. It was 33%. That doesn't really describe a highly functioning healthcare system. We have a dysfunctional healthcare system. We spend roughly $3 trillion a year, and about a third of that, $900 billion, is for waste, inefficiency, fraud, and abuse. That's 6% of our GDP goes to waste, inefficiency, fraud, and abuse. And that's in spite of great physician care. I'm looking at our provider anchor partners. It's in spite of case management, disease management, other interventions that we deploy, pharmacy engagement and adherence work. All of those things, lots of effort, lots of money, and we still have the dysfunctional results of our healthcare system. So it's not working, and it needs to work differently. So hence our problem statement. How do we digitally engage with our chronic, complex, higher cost consumers beyond the traditional healthcare continuum, because it's not working, to proactively manage risk, improve healthcare decision making, and offer assistance to patient families? So I'm going to hand this over to Derek in just a moment, but I will tell you that there is an innovation highway. There are people who have tried to develop point solutions to solve this digital question, and there are a lot of wrecks alongside the digital highway, innovation highway. So with that, I'll hand it over to Derek. He'll go into a little bit more detail, and then we're happy to answer questions.
Thank you. So as Dr. Popiel said, we are trying to engage these chronic individuals, members, consumers, in helping them manage their care when they're not necessarily inside the healthcare system. Right? The system is complex. I'm going into the system for care, for physician's visits, for testing. I'm going to have to pay for that care, but most of the decisions and most of my time is spent outside that system trying to manage my complex condition. So I have a cardiac condition. I could have low back pain. My child could have a disease. How are we managing that condition? How are we supporting those individuals in making good decisions? So our focus here is helping them make good decisions outside the system by giving them some digital tools that can support them across a spectrum of care decisions. What are those decisions? Everything from how do I get involved and inside the system when I need it? How do I manage my life and engagement when I'm not managing my condition? Healthy eating, transportation. How do I ensure that I'm getting services that I need to have to make that condition more conducive? It could be scheduling appointments. It could be getting to the right pharmacy or to the right lab components. It also includes the fact that many of these conditions, these chronic conditions, are with people who are not managing it themselves. So I could be the parent of a child with a chronic condition. I could be the child of a parent with a chronic condition. So not only are we trying to manage and help and support that outside the healthcare system, but we want to do it for the caregiver as well. Because the caregiver is often forgotten in the process. So how am I helping my parent manage that service? How do I make sure they have food or they can get transportation to an event? How do I make sure that they're getting the medication or taking the medication? What are the components around that? So to Dr. Popiel's comments, there's a lot of point solutions out there to address very specific components of a disease state. Looking beyond the disease state for somebody with a chronic condition, how do we help them manage their life? And we're looking for the tools that can help them do that or help their caregiver do that in an effective way possible. So let me pause there. I think we're close to 5 minutes. I might have 30 seconds left. That was close. So I think we'll open it up for questions now for Dr. Popiel and myself regarding the comments here. I know we did a good job, but you know. We have a question right over here. Microphone's coming over to you.
In terms of the solution, how open-minded are you to think outside the box?
I think we want to be way outside the box because traditional solutions have not worked.
And do behaviors like the NFL Super Bowl where they have sold out and they don't have a problem with people participating, that would be okay?
Not here. You may have.
Let's not use the NFL as the best example here. But to Dr. Popiel's point, we do want to be outside the box. And what are we thinking by that is we want the ideas that healthcare organizations, right, may not be engaging or may not be thinking about right now. So we are looking for those things that can really engage the patient, the consumer differently. And if there are things outside the industry, we'll look at that, absolutely. Jeff.
Hi. I hear you saying you want a forklift change. And in my experience, few forklift changes actually work. And given the complexity of the healthcare system and the integrated nature of it, you can't have a forklift change without changing the aligned interests, I would think. That's in addition, in contrast to a migration path to change. So I'd like your comment around that.
So the way we're looking at this is not from inside our company or inside a provider organization. We're looking at this from the perspective of a consumer experience and the journey that they go on in their healthcare experience. And if you think about it, an individual who has a chronic condition spends very little time in a physician's office. Most of that time is spent on their own, and they're left to having to navigate through the healthcare system with whatever resources they have. And so what we're trying to do in that is think more creatively about what kind of assets can we bring, what digital assets can we bring to the experience once a patient or a consumer leaves, a provider or a physician's office. That's what we're trying to solve for. So I'm not sure if I answered the forklift question, but we're really trying to understand do real journey mapping and understand where the barriers and impediments are for somebody to get the care they need. We also want them to be materially informed about their options, goes beyond shared decision making so that they get to choose based on their wants and needs in an informed way about how they want to receive care.
At the edge.
Is it exclusively external?
Yeah, at the edge.
I
understand putting the consumer at the center of everything being done, but I'm not sure the change that you're asking for can be done exclusively external to Regence or anybody or Regence partners.
Well, I think it involves all constituents, but it must have, and a lot of people like to use the word consumer at the center. It's really consumer driven. Somebody used that term, you used that term earlier today. It's got to be consumer driven. So is it at the exclusion of us or providers or other healthcare professionals? No, but it's got to be driven by the consumer. And the only way you do that is you start treating a healthcare consumer like a consumer, which we don't do in healthcare.
For example, with, I work in precision medicine. Asking a health system to take on precision medicine is massive. It's a total overhaul. It's rethinking how you approach medicine. It's expensive. You're changing the way your physicians are thinking about medication, but it is what patients want. We have patients ordering direct-to-consumer tests who are then afraid to bring it to their doctor because their doctor doesn't understand it. Are you ready to do that, or do you think that that's a decade or two away?
Let me start there. So the answer is yes. I think back into the context and framing of this question, right? If you or someone you know has a chronic condition, they are well educated on that condition. They're well educated in the services they need to obtain, and generally speaking. And certainly if you are a caregiver to a parent or to a child, you are demanding that level of precision medicine or outside the box thinking to get there, because you really don't care how the system operates, right? You care how the system operates for you, and you're going to operate that way. And I know Dr. Popiel in his practice, I was a nurse for several years. I still am a nurse. My wife reminds me I'm no longer a nurse, but we see those behaviors all the time. So I would say yes, we're ready for that change. And I do want to reiterate that as Regence, as a nonprofit, we do have a cause and a mission to make things better for the consumer. And so ultimately, how these solutions are developed and executed is very much, even if it's outside our normal operating rhythms, are very much within our frame as an organization for the consumer. So I think that does very much marry where we're thinking.
You mentioned you want a digital solution, but for these patients that you're describing that are typically more of the hot spotters that end up costing our system more money, have you analyzed how much access they have to digital technology and also their engagement with it? Not just access, but engagement with it.
Yeah, and you bring up a great point. So if you're really acting like a consumer company, you're going to want to know who your target market is. You're going to want to develop insights about that target market, and you're going to want to capture individual preferences about how they want to access, how individuals want to access care or navigate through the healthcare system. So there are some, my 91-year-old mother FaceTimes with me and uses an iPad every day. There are plenty of other people that would prefer just to go to a physician's office and feel that personal contact. So you've got to get not only the insights about segments, but the individual preferences, and use those preferences in the way many consumer companies use them for their purposes.
Yeah, I think one problem that probably most of the entrepreneurs here have is there's a lot of different systems out there. I don't use Regence currently, I have in the past. It would be very useful if there was some sort of test account where you could come into your system and just, here's a pseudo patient, it's not a real person, there's no privacy, but so we could understand what that customer experience is, and maybe one test account that's a senior, another that it's a young family. Because otherwise, I'm pitching based on my experience with a totally different system, which may not match yours at all. So it's more of an ask for you. Are there ways that we can understand your system that don't violate all the normal sort of protections you have to have?
And I'll just give a simple response. I think yes, and obviously there's caveats there. I don't think we're going to really transform our healthcare system and become a consumer-driven healthcare system unless the constituents that are ensuring, delivering, and facilitating partner in a different way than they partnered before. So I think partnership requires trust. Trust opens up the door to transparency, and transparency allows us to understand where there are opportunities and close gaps and create a better experience for the consumer.
Just a quick segmentation question. How do you think about chronic care in this context? Is it just the big six? Is it truly chronic patients, whether they're COPD, CHF, hypertension, the sort of classics? And then within that, do you prioritize or segment that population according to your product lines, or what's your priority within chronic care?
So you're asking a question about how do we traditionally manage, and I think the answer is we focus on all of the major chronic diseases that drive either poor quality or higher cost. But we're talking about something fundamentally different. We're talking about understanding any one of those individuals in any one of those disease states and the experience and journey that they go through, and how can we make that experience better to drive higher quality and ultimately to drive lower cost.
Back here. From the standpoint of targeted disease states that you'd like to start with or focus on? And then also from the standpoint of, do you have some specific employer partners or certain populations that you'd like to target first?
So we would like to have all of you tell us where to start. If there is a disease state or a condition or a population that allows us to bring this solution to market, to test it and bring it through, we'd be welcome to hear that. It could be asthma, children with asthma, it could be cardiac conditions, it could be traditional things, non-traditional things. But again, I think back to Dr. Popia, I think it's about identifying and bringing them through the journey. And I think from that perspective, we don't have a preconceived notion of who we want the solution to serve. We have a preconceived notion that the solution should do the best at engaging and supporting them in this journey. And so where that starts, we're open to those suggestions. We are going to get the hook. So on behalf of Dr. Popia, we appreciate it. Thank you very much.
So we're going to do a quick 5-minute break, and then we will reconvene with the next problem statement pitches. All right, that was a quick 5 minutes. Time to move back to your seats. Hello? Is this on? Everybody, we'd like everybody to take their seats so we can get on with the next pitch.
That is not great.
All right, we need everyone to please be seated so we can keep moving along.
All right, we're going to get started with this next pitch from UW Medicine in about 30 seconds.
Hello? Can you hear me? Do you guys want a seat? Like, those are all my friends back there hanging out at the bar. So I'm Gianna Davidson. I'm a general surgeon at the University of Washington. And my job is really to take care of people at the time of total crisis. So these are people, for the most part, that are either going along their course of their chronic care and then they have a surgical emergency, or they're minding their own business and they have appendicitis, or they have diverticulitis, and they end up in my emergency department. The reason that I'm really interested in that is I'm interested in getting patients back to home. This is one of the big challenges with UW Medicine. We take care of really complex patients, and then we try to hand the baton off to other providers within the healthcare community in a variety of different settings to try to help people get back to their baseline health. So UW Medicine aims to be a healthcare home for patients. We want to practice efficient, effective, and high-quality healthcare. In addition to this is a huge system. So they pride themselves on research, on healthcare, as well as medical education and a variety of residency programs. So there's 8 entities within UW Medicine, and I want to give a brief introduction to this because all of these entities really have similar problems. You have Harborview Medical Center, which is the level 1 trauma center within a 5-state range. It also takes care of all emergent stroke patients in this region. We have the University of Washington Medical Center, which takes care of, makes major advances in oncology. We take care of transplant patients. We take care of very complex surgical patients. We have Northwest Hospital, Valley Medical Center, both big systems within bone and joint. We have the neighborhood clinics and hundreds of physicians within the community. We have the medical school, Airlift Northwest, Children's Hospital, and all of these entities discharge patients back to their community. And we'll talk a little bit about what post-acute care is. Has anybody here heard the term post-acute care before? Excellent, you guys are ahead. So following a hospital stay for injury or illness, patients continue on with their stay outside of the hospital. It used to be 10 years ago, if a patient came in for colon surgery with me, they stayed for 10 to 14 days before they went back home again. So they really had reached a steady state. And at this point in time, most elective colon operations, patients stay in the hospital for 3 days. So as you can imagine, even though they're ready to get out of our cafeteria, back into their own bed, not being woken up all night long for their vital signs, they really are not really at a steady state again. And so we transition patients with home health care, having physical therapists, occupational therapists. They have long-term care settings with skilled nursing facilities. There's over 280 in Washington State. We have inpatient rehab facilities at our centers. Palliative care and hospice is another whole component of post-acute care that helps to take care of patients along the continuum of their health care. So there's a lot of unique challenges, and really what we want to target in this space is the skilled nursing facility. Of all of the patients that get post-acute care, about 60% of those go to skilled nursing facilities. So University of Washington Medical Center as a whole discharges to about 200 facilities, as you can imagine. So despite the fact that it's a complex inpatient setting, it is a really complex outpatient setting. This is like the Wild West of healthcare still. So there's about 6,000 patients discharged here a year. We have really separate isolated healthcare system. There's no skilled nursing facilities that are owned by UW Medicine, although we have medical directors from our system within these facilities. So our current state is that we have these black boxes of healthcare. What we'd like to have is an organized and efficient system to really tackle these transitions of care areas. The nurses in the room know that warm handoffs is the ideal. It's when the nurse at the hospital is able to call the nurse at the facility, both of who, well, one will know the patient and one will be accepting the patient when they get there, and tell them these are the important things that happen with transitions of care. These are the important things that matter to this patient for them to continue getting better once they get to the facility. We need that fluid communication that can be stored, updated, and accessed in different systems that have separate EHRs. From the facility side, they need to know, who do I call? If I have just a quick question that doesn't really require the patient going to an emergency department or bouncing back to UW Medicine, who would I know? What's the ideal, cardiac medication? Or did this wound really look like this 3 days ago when the patient left the hospital? We need clear communication for the healthcare partners for these complex patients. So this is a really simple graph just depicting where people are. We have the pre-hospital setting, patients of course that haven't come to us yet. Maybe they're planning to come to us or maybe it's an emergency. They come to the hospital in the second phase here. The transition of care period is the time where people are really planning for discharge. The healthcare teams are starting to say, what do I need to take care of to get this patient successfully out to the hospital? And where's the facility that's going to be able to accept them, both their complex care needs as well as someplace that the family wants to go? They go to the skilled nursing facility and then eventually, hopefully, they're able to be discharged home or to their primary care provider again. So in the red boxes, we've outlined some of the real challenges for this. First of all, the hospital team may not have all of the information that manages a patient's chronic illnesses. For instance, if a patient comes in and they have a medication list 500 deep, they may only remember 10 of them when they come in. As they transition to the care, us getting them back to their baseline and having really accurate information about what have the primary care providers known about them for the past 10 years to get them back to the baseline. How do we get that information and transition that information to the skilled nursing facility to ultimately get them home again? We know that the information that are sent to the skilled nursing facilities may not be entirely complete. There may be components of that missing, or they may get a lot of duplicate information or information that's 3 days old because a huge packet of 800 pages goes to them. The most important pieces of information are buried within that packet. So I want to talk to you just briefly about a case. This isn't a real case per se, but I think it very clearly illustrates some of the problems with this. We have a 75-year-old man. Say he's at home. He's doing pretty well living at home, needs some help from his neighbors once in a while, and he has a history of heart failure. He's going about his business and he develops abdominal pain, comes to the local emergency department, and is found to have a perforated colon from diverticulitis. He ends up in my camp, MultiCare. We take him to surgery. We take his colon out. He eventually is getting better. And as we're planning to get him back to the hospital, it's 4 or 5 days later. His mental status isn't real great. Maybe he needs a lot of work with physical therapy. And so we realized that the best thing for him and the safest thing for him is to get him physical therapy every day, occupational therapy, work with the teams that are going to make him strong enough to get him home again. So we send him to the nursing facility. He's just had major abdominal operations, so he's not really eating all the things he would normally eat. And after about a week in the facility, he starts to get his appetite back. He's getting stronger with his physical therapy, occupational therapy. He's starting to gain some weight again. And all of a sudden, he's getting short of breath. And it's because in all of the transitions of the complex things that have gone on, we missed the information that he was on a low sodium diet, that his heart failure was just barely titrating before he was in the hospital, and suddenly has a problem. And so 2 weeks later, there is an avoidable readmission back to the hospital for something because we've knocked him off his baseline. So we know that these transitions of care are really vulnerable for patients. We know that many of these are also preventable. There's a diverse clinical teams. All of us are specialists within our one area. There's multiple medical record systems. Like I said, there's over 200 skilled nursing facilities we discharge to. And the system is constantly changing information about a patient's healthcare needs. So even if the nursing facility gets a perfect discharge summary with all the information they could possibly need about a patient, 3 days later, there's additional information that maybe changes exactly what that patient's needs are for that day. And then they come back to the hospital, and as you can imagine, this needs to be continually updated to provide optimal care for patients. So we need solutions that help everyone involved caring for a patient to better understand their most up-to-date clinical status. And we need to capture this real ideal warm handoff to be updated in real time, to be able to be identified and seen from all providers along the healthcare continuum. So with that, I'll take any questions.
So this again is a huge problem, sorry to say. But let's say, not to do solution brainstorming, but, a simple way you could have caught the 75-year-old patient is if you had their electronic records available across multiple health systems, then is something like that is doable on a per consumer healthcare patient level. But trying to solve every EHR interaction is a difficult problem. Would something like that solve your problem?
Yeah, it's almost like you need a dog tag, right? Like a virtual dog tag that gives you just the information you want, just the information that you need that can be updatable in real time. Part of the problem is once I discharge a patient to a skilled nursing facility, they actually employ really wonderful providers that titrate things. They come back to my clinic for a 20-minute appointment, and I have 200 pages of med recon. And so it's also getting the information that you need.
So Blue Button would solve your problem?
I don't know what you're saying. I know Blue Button is the app that had come out quite some time ago from Apple.
It's a veterans hospital implemented patient health record that you can carry with you. Imagine carrying it on your phone instead of on paper.
Yep. The problem is it has to be updatable by all members of the triad.
Sure. If that worked.
If that worked. Yeah.
Well, hi, this is John from Verizon. You have multiple entities like Valley, Northwest Hospital, and others, right? How do you handle the disaster and emergency cases when it comes to network device or patient engagement? And you can widen that to other entities within the healthcare, within Washington or others, My point is, do you have any kind of plan to engage with the patients when there is a kind of like emergency earthquake or any other like wars or whatever? So do you have any security for the data? Do you have any backup for the data? How do you handle the blood suppliers? Do you have any kind of communication?
Yeah, so Harborview Medical Center is the level 1 trauma center for this whole region, 5-state region, and they do have disaster readiness plans.
Okay. So, the patients wouldn't have any problem if there's a kind of like an urgency, and you'll be able to get the data about the patients in real time, or you can share that data, or you can work with the blood suppliers or ambulances. You have everything all set. Is that what I'm hearing, or?
So the disaster readiness plan and preparedness plan is all done and coordinated through Harborview. You're bringing up a lot of different parts that go into disaster preparedness. Exactly. That kind of goes beyond the scope of this.
Thanks.
Hi there, my name's Dave from Twistle, and my question is actually, have you thought of engaging the patients while they're in the skilled nursing facility.
No, we don't like to talk to them.
Maybe not.
I like my patients intubated. Yes.
Okay.
So
Fair enough. Hey,
I'm absolutely kidding. So we actually have a whole patient engagement portion of our research group that's actually ran by two of my partners over here, Anna and Elizabeth. And so we do have a stakeholder group of patients. And a huge part of what we did in the beginning of this was hearing the stories of how challenging it was for them and for their caregivers as people went to different healthcare entities. We'd say, particularly surgeons are the worst, right? We'd say, yeah, you're just going to go to that facility for a little while, like 2 days you'll be home.
Right.
And then the facilities would get them and say, like, thanks guys, like the patient hasn't walked in 3 months. And so there's a lot of problems with these kind of communication, and part of what we're doing separate from this is really building that stakeholder engagement piece.
right. One of the reasons I was asking is because it gives you a conduit to kind of almost surveil the nursing facilities and understanding if they're delivering the care that you expect them to give.
Yeah, it's really interesting when you look at patient satisfaction versus like the CMS quality scores, which is how we rank nursing facilities.
Right.
They're not congruent.
Sure.
Yeah.
Okay, thanks.
Thanks, Dr. Zabe, for the talk. I'm actually a recently graduated plastic surgeon. I just relayed to general surgery first, and I understand where you're coming from about talking to patients and how surgeons are some of the worst. It seems like a lot of having a healthcare giant like UW, the complexity of the holistic approach, different people in the workflows, improving communication through making networks between physicians and ancillary staff or non-physicians. The low sodium example, only a physician could really pick that up. A nurse could pick it up, but a physician would make the clinical decision on what to do with it, and whether it was an EMR or not. If they didn't see it, it wouldn't matter. It would be the same outcome. So I don't think an EMR or documenting would help. And it's about getting the right information to the target decision maker in the workflow, I think. For example, when you come into workflow for appendicitis, the ER doctor sees you, but they're not the ones that's going to be making the decision whether to operate or not operate. So if you had that information directly from a transfer from one of your satellites, that would definitely speed up the workflow and reduce the cost. And I think a solution that would improve the communication between physician and non-physicians is maybe if something that UW is looking at, where skilled nursing facilities with wounds and chronic wounds, where you can have photographs that can be shared that are older comparing to newer photographs, managing the patient that way, wound care and all that, efficiency improving, I think. Is that something you're looking for?
Yeah, it's complex because different, patients with wounds are a totally different subset of patients than the heart failure patients, which is totally different from the joint patients. There are a couple of projects that we're looking at there's a project called Empower that looks specifically at wounds, but being able to incorporate them to the providers in the nursing facilities and then feed that information back has been a real challenge. Okay, back here.
I was wondering, how do you hand off information today with these nursing facilities, especially if they have different EMR systems?
Yeah, the standard of care is actually the discharge summary that goes with the medical, reconciliation form. The problem is the discharge summary, our standard is to have it done on the day of discharge and to go with the patient, but really it doesn't have to be there for 30 days. So the facilities that get them, there's a long delay often before they get the copies of all of those records for their patients. And then they don't even have to have a provider see them for 30 days. So a lot can change in that time period.
Fax? Or, if it's 30 days, is it by turtle? Or?
It's usually faxed.
Okay.
Yeah, at the system, but every system and every, we've looked at a lot at the process and flows. It's actually different even at UW Medicine itself at each floor. But the standard is as the patient leaves the hospital that it goes by fax with them when the patient leaves. So hopefully it's there at the same time.
So could you go out on a limb and tell us what you think your 200 discharge facilities might say about because it seems to me it's a two-sided communication problem,
absolutely.
right? So if you could role play that side of it, because I don't think we can fix it just from your perspective.
Yeah, I think you're absolutely right. The facilities, we have an organization called Inform that we built actually with the facilities. So we were surprised as going out into surgeons into facilities, we thought they were going to say, what are you guys doing here? Like 100% joined and said, yeah, we'd love to be a part of the solution. They want to take the best care of these patients. And the things that are real challenges for them is the same problem that we have. They get stacks of papers, physical therapy notes from 2 weeks ago, and trying to find the important clinical data within this long ream of information. And then in addition to that, being able for like the medical reconciliation form, what they find out is the medications that the patient should take the day that they get there. What they don't know necessarily are what are their home medications? How do we anticipate their fluid shifts are going to happen over the course of the next 2 weeks? So then what should their medications change to be? They don't have that insight into it. There's not a system to really build those things in.
We'll have to call it there, but thank you, Dr. Davidson.
Thank you.
Next, we're going to have our MultiCare team come up, starting with Teresa Boyle.
Thanks, Avatar. Okay, so what I get to do now is spend just a few minutes introducing MultiCare Health System to you, and I do that as context setting for the problem statements that you're going to hear. So as I talk about MultiCare for just a couple of minutes, what I want you to keep in mind and what I would like to impress upon you is that we are a broad-based healthcare system that goes well outside of Pierce County as well beyond acute care. So those are a couple of things that that I just want to make sure you understand as you hear the problem statements. Our mission is about partnering for healing and a healthy future, and our vision is that we will be the Pacific Northwest's highest value system of health, leading as a people-centric community asset and integrating a full continuum of high-performance, customer-focused health and health-related solutions and delivering world-class health outcomes and exceptional experience at a competitive price. Our organization, our heritage dates back to the founding of Tacoma's first hospital in 1882. So we are grounded in acute care as a part of our history, but have grown substantially over since 1882, obviously. We're independently owned, nonprofit organization that is governed by a board of directors, largely from the Pierce County community. And today we care for over 500,000 patients with care sites in 5 Western Washington counties. This slide, I think, really describes kind of that full continuum of care and gives you a broader perspective on who MultiCare Health System is. So we have 4 adult hospitals. We have 2 hospitals on deck that will be up and running in the next couple of years. One will be out in the Covington area, and then a psychiatric hospital that we're joint venturing with the Franciscans in Tacoma. We have a pediatric hospital. We have 2 big multi-specialty centers, one of them with a freestanding ED, inpatient rehab programs, 5 outpatient surgery centers, home health and hospice. We have several imaging joint ventures across 6 sites of care, 9 urgent care centers, a behavioral health network, 11 retail clinics, and we provide occupational medicine. So again, well outside of just the acute system of care across a broad continuum. These statistics here just give you a little bit of an idea of the population that we're serving, and over 1,100, or we have 1,130 licensed beds, and over 217,000 ED visits per year. We are the second largest employer, or one of 2 large employers in Pierce County. Us and the Franciscans are the largest employers in Pierce County. We have over 10,000 employees and 695 provider FTEs that are employed. And our provider FTEs are distributed across a broad range of provider types as well. And then finally, this is how we think about our alignment and our strategies. So up at the top, you see the 5 customer groups that we service as a part of our system of care that we work to deliver our mission, vision, and values to. In the middle here is really our delivery system and how we think about ourselves all together. And then our three big strategies that we are driving towards is, first of all, performance excellence across employee engagement, top decile of quality, top decile of service, and then the lowest quartile on cost and the highest quartile performance on margin. Population-based care, we are moving to and transforming to become a population-based system of care, and then expanding our market presence and access to care and services. So that is a little bit of context about MultiCare Health System. And with that, I'm going to turn it over to Dr. Hooper to introduce our first problem statement.
Thank you. Okay. So our first problem statement really has to do with communication, and we really feel communication is a true foundation and a key to success with any organization. And we really started to look at how to look at our communication and really looking at streamlining communication between provider and the care team, between care team member and care team member, and between our care teams and our patients. And so some background with that communication. Currently, our physicians and our care teams carry a lot of different devices and use a lot of different modalities to have communication. It can range from having Tiger texts on your phone, having the original pager, they still exist, having Epic, communicating via the verbal communication, or even our old-fashioned paper and pen. And when we have that many types of internal communications, it's only a matter of time before something can mishap and we can lose a key important fact of a patient's health care, and that could lead to detrimental outcomes. So what we're asking, and really our problem statement, is what tools and technologies can MultiCare implement to streamline internal communication between care teams at MultiCare with the ultimate result of improving care coordination for our patients. So an example of that, because that can be pretty broad, say we just had a surgeon come up. So surgeons tend to order some labs right before they go into the OR and then go into the OR. So if our surgeon orders a CAT scan and some labs and then goes into the OR, in our current state, it takes them after they finish with the OR to look at those labs. In the meantime, we might have nursing staff and other staff looking all the time at the computer. Is that CAT scan done? Is our labs done? Calling the lab, calling x-ray to see if that's done. And so there's no communication. We come out and we're being more reactive instead of proactive. And that little delay in communication can be detrimental if we have a critical value that our patient that we need to look at stat. So we really are looking at that communication aspects. And you say, what communication, what's the impact? So we just thought about a couple of things that impact when we do have a lack of communication. One, we see an increased length of stay. How's that? If our physician can't communicate with our social work that it's time to discharge a patient, then that can increase our length of stay. We can also have some increased frustration and lack of trust with our patients. How can I trust my provider if they've delayed my communication about my lab results? How can I trust my care team if there has been no communication? And how can I trust my health to any organization if I have multiple communications? If multiple people have told me the same lab results and I haven't gotten an answer by why? So all of those things lead to frustration and a disconnect with our patients. And we feel that these scenarios really negatively impact our quality of care, decrease our patient satisfaction, and can increase the cost of care. I kept it very short because I wanted to be under the 5 minutes, so I will leave it up to questions and answers. No questions?
So you're using Tiger text, so that, I mean, you have decent kind of communication tools, right?
It is, but it doesn't really communicate with the whole health team. So what
So
I
other
mean-
people can't see that
Other people can't see it. Our patients can't see it. So we also include the patients into that communication realm. I think that's the missing piece. We can communicate also amongst our care team, but not everybody uses tire text. If I'm in a certain part of the hospital, sometimes it could go down. And then how do we get that patient involved into that communication? Most patients don't use the tiger text.
Fair enough.
Do you have any patient-centric dashboards?
Looking at my people's.
In terms of what specifically?
Do you have a global view of what's happening to the patients, what's being done to them, for them, and is the problem really getting that information out to the hands of the broader care team, or is the information not present in a particular place?
So those dashboards do exist in certain environments. For example, in the emergency department setting, there are dashboards that have de-identified patient information, so you know who and what condition is represented in your emergency department at any time. Are they in the emergency department? Are they off the unit having a study performed? Those sorts of things. Some of that exists in the critical care environments as well. The challenge with that is it's still a static piece of information. And what we're really kind of talking about here is rather than trying to pull and extract information or going to a dashboard, whether you can log on to that and view it from a remote station or not, that's still having to pull information as opposed to having relevant information pushed to you real time.
Other questions, comments, concerns?
Have you heard of open notes system? I think Harvard View has used it where patients can see into their own records that the doctor may write about the patient. Are your providers open to letting patients see this open communication?
We are open to changing healthcare. And so we really want to engage our patients, and we haven't done that efficiently. Otherwise, we would not be here today to look at how to think differently outside the box. So that's our goal, is how do we think differently? I think part of any innovation is really making sure that the patient's at the heart, and that's for any provider, that's what you want. You want the best care for your patient, and you want to be able to treat them in real time. You want to communicate with your healthcare team in order to provide that healthcare. Wouldn't it be nice if when you go and discharge a patient, I said to the patient, Mrs. Jones, you're going to be discharged, bing, everybody knows at the same time, so that we can start moving the ball and not people having to catch and be reactive about that information.
So what's the time frame you are looking into? Let's say with some solution you pick. So is it like a Q2, Q3, Q4 time frame?
Teresa, I don't know. Question? I think.
I'm sorry, I don't quite understand the question. Well, we're on the time frame that same time frame as this, so we would entertain the solutions. We'll be interested in establishing a pilot, and then as a part of setting up the pilot and the letter of intent, we'd establish the timeline for a rollout. So I don't know that today.
Yeah, so to give you a little bit more insight, so we spoke briefly earlier about the full process that we're going to go through with the Elevor Labs program, and the final LOI will be given out for MultiCare later in this year, in the next couple of months, and then from there, depending on the specific type of pilot you're going to be implementing, the scope and all of that, that will be later determined. It's really going to be dependent on the solution that's being implemented, specifically how it's going to be scoped out within MultiCare's ecosystem, and how they want to implement it. But the program will be held over the next couple of months, and the actual specific dates of the implementation will be figured out then.
Specifically, does this solution have to be able to interact with your EMR?
No. It doesn't. Be nice, yes. Does it have to? No.
Have you implemented Tiger Text? How's the compliance been with the Tiger Text app? Is all the physicians and nurses how much percentage of your staff, which is probably in tens of thousands, I don't know, are on the Tiger Text app?
That is my inpatient team. Where's Harold?
8% of those right now. It's still in the process of being rolled out across all of our facilities. So it is pretty well rolled out at the physician community, not as much in all of the frontline clinician staff. So I think the question is really, there are so many streams of information that are coming as communication bits. So what we're asking for is how do we pull those together? And someone raised this question earlier. How do you put the information that's relevant for patient care in front of the caregiver at the most appropriate time possible? So it's really about taking the many tools, the many different communication streams that we have available to us and putting it together in a way that surfaces that information at the right time.
Can you describe the process that you used to come up with those 5 bullet points of the consequences of lack of communication?
What's the process? It's
No, what was the process that you used to come up with those list of 5?
Oh, a lot of it was coming with our providers and what they've heard from our patients also, sometimes through Press Ganey in the comment sections of things that they don't like about the system, and a lot of personal experience from patients and from our staff. So these are
simply
examples. Yes. Yes. I mean, it would be longer than my 5 minutes if I had the big list.
All right, if there's no further questions, I think we can
I'll
move
pass
on
it
to-
over to Chris Cordell.
So I'm Christopher Kadama. I am a pediatric hospitalist by training, but have the privilege of leading our accountable care activities at MultiCare Health System. So this next problem statement is very near and dear to my heart. I also realize that this is the last reverse pitch for the evening and I stand between you and your cupcakes. So I will do my best to make this worthwhile for you all. I use the word patient activation here, but really, as Nicole mentioned at the beginning or the top of the presentations this evening, one could easily substitute broader terms like consumer, because not everybody identifies as a patient or may have an active medical condition. So I would encourage you to think with a broad lens on this. So in terms of a little bit of background, there are many patient education tools and wellness goal aids and well-intentioned services available, both that we use at MultiCare Health System and that are available broadly to the public. So how do you help folks sift through all of that? And I think Kat mentioned this during one of the Regents' comments around curating and filtering out a lot of that background noise to get to the key resources that help empower individuals with actionable information, the critical data or information that's going to help them engage and understand and manage their health condition. And also the resource interfaces can be quite user unfriendly or overwhelming at times as well. So from a problem statement perspective, the way we have articulated this is the question of how MultiCare can empower these communities, as mentioned, to draw this actionable information out in a timely manner that's engaging for them, whether that's fun or if that's something that's more academic in nature, but to meet their needs, to also help them accomplish their wellness goals and understand what those might be, and then to monitor their health and ascertain the right place to go when they do need care. So here's a different way of looking at this. Sorry, the animation got a little lost in translation here, but in essence, there are at least 3 activation facets that we wanted to articulate and share with you this evening to try and drive this point home. In other words, 3 facets or aspects of healthcare that an individual may encounter that will kind of make or break how engaged they feel in understanding their healthcare needs and partnering with us to manage their care. The first would be services and resources. So the types of questions like, do I actually need care? And if I do, where or how do I access that? Someone mentioned earlier about the importance of human connection. So there are a lot of different options that we have designed it to provide to meet people at their level and provide the most appropriate care at the right time. So that could be an asynchronous email type of a visit. It could be a face-to-face virtual synchronous visit. It could be an in-person visit, but really getting beyond this bricks and mortar sensibility to kind of appeal to a broad set of solutions. And how do you stay healthy? The second facet around potential engagement or disengagement would be business transactions. And you heard some of this earlier this evening. Is this covered when I do seek care? What's my out-of-pocket expense? Having some degree of transparency around this to help guide some decisions so that they feel engaged and informed in the decisions that are being made. Care milestones. So what are my health goals, which are oftentimes determined in conjunction with the primary care provider, or an individual may come to us as providers with those already predetermined so that we can work with them in achieving those. What do I do on a daily basis in order to achieve those goals? And how do I actually remember? Because there's a lot of stuff to keep track of. So to round out this problem statement, we wanted to share sort of a composite profile of a potential individual. Now, this gross oversimplification, and it sort of speaks to this interesting paradox, that there are certain universal characteristics that you will see in this composite profile that represent across broad populations. But what we're also trying to do is reconcile that with this notion of mass customization. How do we meet an individual to meet their individual goals on their level with their learning style and how they prefer to gather information when we are moving away from having to do, well, where we're having to do this more with less resources or less of the traditional resources. And that's one of the reasons why we felt this was important to talk about this evening, was what are those disruptive innovations that can help us scale this up very quickly. So for Maria, in this case, you have a 46-year-old busy mother. She works, she has 2 kids. She happens to have diabetes as well. She doesn't have a lot of time to engage with her primary care provider or go to doctor's visits. She wishes that she could keep up on the literature a little bit more on diabetes and how to stay healthy. One of the things about Maria is that the limited amount of free time that she does have is usually the downtime between shuttling her kids between extracurricular activities, which, by the way, one of her kids has asthma as well. So she's always on the lookout for how to engage in actively and proactively managing his care. She's also very interested in social networks, leveraging the wisdom of the crowd. She engages in this in a lot of social aspects, but would be open to having social communities that could help her or that she could help others in supporting, this is what works for me, the sort of hacks or workarounds that people come up with, the innovations that people come up with in managing their chronic disease. She also would like to be able to keep track of her activities, inform herself about better dietary choices and track those as well, but the amount of information out there that's available to her is vast. It's so overwhelming that given the limited amount of time that she has to spend on this when she's not focused on work or helping her family is oftentimes overlooked. And finally, from a prompts perspective, and this speaks to the how do I remember to keep track of these things, even if she understood all of that, having a minimally intrusive way that would help her keep track of the sorts of activities or the best practices that will help her achieve her health goals would be very helpful. So this is Maria in a snapshot, but I'm sure there are elements of this that you may recognize for yourselves or other loved ones that we try to pull in here just to drive home the point that in this, as we pivot away from hospital-based care, as Teresa was referencing, looking more at providing and partnering with individuals and other partners to manage populations and the health of a population to keep a broader number of individuals healthy. How do we actually do that? And one of the ways we need to consider is how we activate and engage those individuals themselves in partnering with us more, as opposed to us telling them something, having them go out on their own into the wilderness and navigating a lot of these choices on their own. So the good news is there are a lot of resources out there. The challenge is how do you help people drive to the select few credible, actionable ones that are going to help them manage their care. So that is our final problem statement for the evening.
Questions?
I have a question regarding the business model here. So if you're successful in this, you'll actually reduce your utilization. So how do you sort of capture that value?
It depends on the utilization that you're talking about. So in general, when you look at managing populations better through these sorts of activities, certainly utilization, one would hope, of those most expensive, most intense resources like hospitalization, critical care units, emergency departments would go down. We also suspect, though, that as you create that capacity, there are others out there who probably really need it. And so if you can provide a valuable service and a relationship with populations where they want to seek you for care, then you'd be able to backfill that. The other opportunity here is in terms of the work that I do in transforming some of the reimbursement models to align with and reward this activity so that you have the sustainability.
It seems part of what you're asking for is, from an information management perspective, an up-to-date service, but for patients, not for doctors and providers. Is that
I
a
would
fair
certainly say that
characterization?
falls within the canvas that we tried to paint in those three facets. It doesn't need to be limited to that. Yes?
Can you speak to Maria the composite in terms of the fun things she likes to do?
The fun things she likes to do?
Yes.
Well, I actually probably could pull the room and ask you all, because that's really what informed this aggregate profile. But some of the things that I think are worth highlighting, one of the things I didn't mention that we do hear and we do observe in human behavior is, even though we don't want to diminish the gravitas of a health condition, that the gravitas of a health, or the seriousness of the health condition is, we also recognize that people are more likely to engage in tools and activities that are fun for them. So, you know, a person like Maria probably plays Candy Crush, would be my guess. You know, so a little clue about what we might be looking for. I think we could come up with the most elegant and sophisticated academic solution, but if it doesn't appeal to the user at the interface, that's a problem. Yes?
And a mother and diabetic, which is probably secondary diabetes, which probably means she's overweight, probably has hypertension on top of that, and is stressed out to death. So the one thing that would really benefit her is having some time not to play Candy Crush, but maybe to exercise or do something. So if you took 4 hours twice a week and provided her with some respite support in her home, you know, at $20 an hour, and so maybe, you know, $800 a month or so to put towards giving her some supportive care in the home or activities for her kids to get out of the home, you would save millions of dollars from the time she's going to end up in the emergency room or trying to manage her diabetes and hypertension and obesity that she probably has, not to mention the diabetes and possibly the alcoholism from playing Candy Crush.
Well, and I think that you've just helped to answer that question as well. And it illustrates the point that every individual, even though this is a composite, may have different needs. So although this wouldn't be in scope for this particular problem statement, we have built infrastructure to help support these individuals in terms of hooking them up with the right types of psychosocial things that oftentimes get overlooked otherwise, but are no less important. So this sort of problem statement is meant to speak to how do you actually get to and enable the identification of what those needs are going to be. And so there's sort of that curation activity that's associated with this problem statement. Yeah. Mm-hmm. So aside from just figuring out ways to get them to the hospital so the family can get a break, you know, looking at reimbursement policies and really recognizing that, you know, we have to be able to identify that, you know, when we look at complex needs of patients, that we need to be able to identify that that has changed over the last 30 years. You know, the definition of complex needs, and maybe respite care needs to be a billable service that will save billions of dollars. Right, and I don't disagree with that statement. I think for the purposes of this particular problem statement, it's not something that we would necessarily expect of a solution. There are other activities, however, to get at that.
Great, thanks a lot, Chris.
Yeah, thank you.
So just a few preemptive logistics before I hand it back to Nicole, or a few preemptive questions. The first question is, so when is the deadline for me as a startup to apply? The answer is April 4th. So April 4th is the deadline. This is for all enterprise clients.